all good to go. And officially welcome to our 3-day EKG challenge. We are kicking it off this time on a Sunday night because we know that most of you have weekends off. So you can absorb the juiciest part tonight. And then if you're working tomorrow, we record those sessions. You can always catch them later. But without further ado, let me make sure that everybody is here. We have some people on Zoom. We have somebody named O here. Oh, go ahead and type in the chat if you have a question. We would love to hear it. We have Michelle here. Yay, we're going to promote you to panelist. We have Tori here. What's up, Tori? We also have Steve. Hey, Steve, I just wanted to say thank you so much for recommending the 3-day out wherever you were recommending it. I think it was in an EMS group. So thank you so much. We have Alfonso, Amy, Elena, Isa, Jennifer, Nuria, Laura, and Sandra here on Zoom. So if you guys want to join on Zoom, you are more than welcome to. You can also join us on Facebook Live. Either way is fine. We will still see your comments. Okay, good. Thanks, O. All right, awesome. Nuria is saying hello. Nuria, it's been a while since we've seen you, so welcome back. Michelle, hello. Do you want to say hi to everybody? We're going to get you off
hey guys.
so you can say hi.
Yes, now I can see everybody. How are you, everybody? Yes.
Hey, Jay in the house. Hey, let me see that shirt you have on there.
Oh, I've got me a new zebra shirt on to match my Skelly, who also has his zebra shirt on. And we are excited. So because Jennifer's coming to San Antonio this week, and we are going to have in-person teaching, and a big group of the people are going to be here this week. So super excited.
Super excited. Yes. And thanks for being here, Michelle. I'm going to see you in a few days. But we're going to kick off our live challenge now that we are officially 5:30 Pacific Standard Time. I'm going to go ahead and grab my slides, and we're going to talk about all the things. So welcome to the 3-day EKG challenge. Hey, Samantha, thanks for inviting some of your people on so we could help them. We always appreciate that. And in this challenge, we're going to be going over a lot of basic material in a way that you're going to be set up so that you can understand it so much better. And we're really excited about that. Michelle, as you just met, is one of our coaches. She's one of our lead coaches, and also she is the group cheerleader. She's our basic EKG instructor in our 30-day EKG challenge. She's been with us a very long time. And if we're lucky, we might just be able to convince her to do a little game for us. She usually does that for us to make it that much more fun. So, type in the chat if you've seen Michelle's games before. If you want her to bring one back this 3-day EKG challenge, please let us know in the chat, and maybe we can convince her. So anyway, without further ado, we also have Tori here, and Samantha says we love Michelle Barkley. We do. Yeah, absolutely. So Tori's also here. Just to say a shout out to Tori. She's our group concierge, and she's available to help you get the workbook that we provide for free so that you can follow along and just make notes. Because what we've learned through this journey is that people learn better by taking notes. You retain the information 25% better is the statistics. So that's a pretty good number. And she's on Facebook and she's on Zoom. So let us know if you still need the workbook. We'll be happy to get it to you. Some people are confused because we send you a link and you click on it and it gets sent to Messenger. And people are like, well, wait a minute. We actually have like an assistant that does that for us, so we can still stay alive with all of you. So it's really exciting. You can print it, you can download it. Some people put it on their iPad and then they sketch along as we go. It's just really fun. So whatever you want to do. So Christy is here, and Christy Tori will absolutely get that for you. Michelle, I think we have some votes for some games. Malika and Kylene on Zoom definitely needs the workbook. So we'll make sure to get that link for you guys as well. So Tori on Zoom. All right. Yeah, maybe tomorrow. That sounds good. I think, Michelle, we have a lot of votes for tomorrow. So anyway, let's get kicked off with tonight now that we've got everybody set up. And I think Tori will any minute post our link in the Zoom as well for you guys. So just a quick little introduction. If I haven't met you before, welcome into our world. Yes, Alfonso, it is recorded for replay. It is going to be stored in the guides section when we're done. We'll also be posting a little special replay page as well. So if you're at work and you can't watch it on Facebook, you can watch it that way too. So really, yeah, shout out to Alfonso, first time on Zoom. Nice. And you already got this nailed down. So yeah, this is kind of like a little bit of a new learning curve, but once you get the hang of it, and if you need help, just let us know. Michelle or Tori are around to help you in the replay, and so am I. Okay, so I'll be your EKG pilot. I'm going to guide you tonight through, navigating the tough world of EKG. I'll be your EKG pilot. I happen to absolutely love that movie Top Gun. Is there any Top Gun fans in here? If so, please type in the chat. Please type in the chat. And then let me know if there's any Top Gun fans. All right. And then so we're going to talk about basically you being brave enough and being negative ghostwriter, the pattern is full. Yeah, there's no Top Gun fans here. So we're going to talk about you being brave enough to accept the mission of maybe learning EKGs in a different way than you have before. Okay. And so that's going to require us to be super bold in doing this in a new way. So a lot of questions came through, and let me just message real quick. Okay. I'm seeing some questions coming through on Facebook. So if I miss a class, where can I find the replays? You can find them in the guide section of our Facebook group, and as soon as they air, they'll be posted up in there, and we'll also get you the link. So it looks like we have a link being posted for the workbook. Thank you so much, Tori, for posting that in Zoom. And also, all you got to do is click that. It sends it right to you, and you'll be good to go. Is there any guests on this 3-day challenge? Yes, there is. We have Michelle Barkley, who you guys just convinced to do a game tomorrow. So that's amazing. And also on night 3, we have a bonus guest, Gary, who will be doing an arrhythmia review for us. That's kind of like a movie. It's really fun. There's dynamic strips. And so definitely make sure to carve out some time to come to that. That's on night 3, which is Tuesday. So we have a varied amount of people in this group. And the good thing about that is we all come from a different place. We all bring a different outlook and a viewpoint, but we also can cheer each other on, because one thing that I fully believe in 100% is that we are all a big team, right? And whether you're running a code, whether you're in the hospital, whether you're wherever you are in the clinic, you're all a team to take care of the patient. And so being that, as it may, everybody is important. The students that are here, we're so glad you're here, because you're going to be leading the future of medicine. So we absolutely want to make sure you understand this. So maybe in other places, students are kind of pushed off to the side, but definitely not here. We have nurses, we have nurse practitioners, we have PAs, we have some MDs, we have actually some exercise sports physiologists that just joined our group. Like literally we have every possible position in this group, because we now have over 18,000 members. So rest assured, you are covered, and we have lots of medics. So talking about medics, I want you guys to type in the chat, okay? Whether you're on Facebook or Zoom, I want you to type if you're a medic, because we have a very special thing going on, this 3-day EKG challenge, which I'm going to tell you about in a second, but it's only going to be available to paramedics, and I'll explain why. So this is our little guest commercial for Gary. He's going to come on the 3rd at 6:30 Pacific Standard, and he's going to be like the dessert. Okay, so it's really fun. It's really laid back, and there's lots to learn, lots to do. Let's see who our EMS folks. Yeah, woohoo for medics. Okay, we have a paramedic student here. Nice. Okay, and we know KJ, you're EMS. Woohoo for medics, absolutely. And your Alfonso's a firefighter EMT medic starting school Tuesday. Amazing. Okay, so you guys are going to be eligible for running for our prize. Now, this is the prize, only available to paramedics, and I just want to tell you why. So we do something called a 30-day EKG challenge. It is something that is a follow-up class to this if you liked this. It starts next week. We do a bunch of real EKGs. We do cases. We start from the basics all the way up. We show you all the things, but we're going to give one person a scholarship to this class. I'll tell you more about it later, but in a nutshell, you really want to be there. Now, only medics are going to be in the running this time. we normally make it available for everybody to be participating in this scholarship. But because this here is my mentor on the screen, he helped train me as a baby paramedic. And because of that, and because he just passed away a couple weeks ago, this 3-day challenge is dedicated to him, Walter Hines, and dedicated to his memory. So somebody is going to get the Walter Hines Memorial Scholarship, and it's only for paramedics because he was a paramedic. Now, I will be giving extra points to a paramedic or paramedic student that is also trying to help other people in this group. Okay, so just keep that in mind. If you can be helpful as well as learning, that was Walter's style. Okay, so we definitely want to know if you're a medic. Looks like we have some more paramedic. Yes, Dennis. Yes, Tadia. Yes, and we have Steve. Right. Okay, this is perfect. So we got you on our radar. Thank you, Alonzo. This isn't to have you guys feel sorry. It's just to literally honor a good man in a good way and give back to you, our community. Okay, so what are we covering about in this challenge, this whole 3 nights? What are we covering? We're going to cover a 10-step systematic approach to reading 12 leads. We're going to cover what a normal EKG should look like. We're also going to cover conduction in the heart, a little bit about the waves, and the secret roadmap that'll get you comfortable and confident with EKGs in a way that you never have been before. Santina, I didn't know that you were a medic. That's awesome. Thank you for chiming in. Again, we're wanting to see who the medics are so we know that when it's time, we can consider you for the scholarship. Okay, so we have a team. It looks like Christina, there is a workbook link 3 things above you. Ruben posted it right there. And you just click that, it'll send it right to you. You're on Facebook, welcome in. So we have a team here who consists of our community manager, cheerleader, game master, like basically just overall wonderful person, Michelle Barkley, and she will be, if you're lost, someone that can help you as we go through the next 3 days together. But of course, there's also Megan, who sometimes pops in. She's our cardio queen. She's an inpatient, outpatient NP, and she runs a lot of classes in our 30-day EKG challenge, as well as David White. Sometimes he also pops in, and he is literally the smartest person I know in EKGs. Don't tell him that. Also, P.S., he's a medic. Also, P.S., he will never admit he's the smartest person, but he is. So if he drops things in this group, pay attention to them, because if there's ever a debate, his answer is always right. There's also another great expert in our group, Ken Grauer, and he also has a lot of good things to say. Yes, he knows all the things. Oh yeah, Tanya, Chris Carlin. Yes, tell him hi. Oh my gosh, so excited. This is so cool. Thank you for being here. So anyway, getting back to introducing me, if you haven't met me, we showed you our team, but I'm going to be leading you through this challenge. And my background is as a paramedic for 13 years. And I transitioned over to being a PA for 16 years, almost 17 now. And I've been in cardiology and emergency medicine the whole time. And I absolutely love my job. I'm definitely not burned out. And I love getting to share what I learned with you to make you stronger providers, because it wasn't always like that. Yes, woo, woo, Megan Walls, exactly. Thanks, Tori, for posting the workbook link. And so at the end of the day, you know, yeah, I know a lot of things now, and, you know, it feels pretty comfortable now, but I put a post yesterday on Instagram. You can go back and watch it if you want to, but I just wanted to tell you guys that it wasn't like that initially. In fact, I almost quit medic school. I almost quit. I didn't feel like I was getting it. The EKGs made me feel stupid. The Dubin's Orange book made me feel even dumber, because I'm not someone who learns from books. Okay, this isn't a confessional, but this is just realizing that here I am now elevating. I lecture nationally all over the country about EKGs and cardiology, but I started at very humble beginnings, just like maybe you are. And so if I can get here, being the runt of the litter in my class, literally, that's what I was. Okay, I was the girl that sat in the back, very shy, very, very, very shy, and didn't really want to ask questions. But I want to encourage you to not be that person, right? I want you to ask the questions like Michelle said, and you're going to have a very wonderful, positive experience in this group, being lifted up. That's what we do here. So welcome it. All right, now, here's the thing. If you're wondering, how did I get here? I looked back and I drew this out And actually, Ruben, our wonderful assistant, you may also see tagging and putting things in the group, he created this he created what I was seeing in my head. He created it for us to show you kind of how to get there. So when you're sitting there and you're, wondering, how can I feel that way, Jen? I want to feel that way too. What's the roadmap to get there? Well, you start with the basics, which we're going to cover in this challenge. We're going to cover the waves. We're going to do rhythms tomorrow night. We're going to talk about some intervals. And then what do the 12 leads, what do they look at, right? What does a normal EKG look like? So we're going to talk about some of this. We'll briefly touch on coronary anatomy, although not as deep as we cover in the 30-day EKG challenge, but it's going to be a taste. And then later, when you get the basics down, that's when you layer on the high risk patterns. I'm not even going to begin to talk about that, but that's a whole thing in and of itself. When you get better, it turns out there's a lot of things that they didn't teach us in school that we really need to know that are high risk, often called non-specific ST2 wave changes that we'll cover in our 30-day, but I'm not going to get into anything high level here. I'm going to try to stay very basic, because that's what we are doing, is laying the foundation. And then you learn STEMI, you learn subtle STEMI, you learn the mimics, and then you get competent. Okay, so that's how this goes. And just proof of what I've told you. Okay, this is me. I was when I became a paramedic here, and yeah, KJ, you're absolutely right. So I was terrified. I don't look it. I was guaranteed, legit terrified every time the radio went off. That's my partner Frank. He's amazing, and I was the paramedic, right? So I had to know all the things, and I was terrified. I didn't know all the things at first, right? So how do you learn it? You learn it because you're scared. And I'm just going to tell you that that's a really legitimate driving force. So that maybe is what drove you here. And if it did, that's good. I say good, good. We want you to be scared, because if you're scared, you'll be safe. And that's the secret they don't tell you. So now that we've kind of laid the foundation for what we're going to talk about, how this is going to work, let's get into the meat and potatoes of the lecture, which is the foundations. So the foundations of EKG is this. You are looking at the heart sending signals to the chest wall, okay? Electrical signals. And we're capturing that on the 12 lead to understand what is going on in a 3D object. So we've got this flat piece of paper telling us what's happening in a 3D object. So that's the first problem I see in learning EKGs, is you have to be able to put it together. What is this? And the other thing is that I didn't know at the time, there's so many things the EKG can tell us that it's unbelievable. It can tell us about electrolytes. What? Are you kidding? Yeah, you know about peak T waves. You probably learned that, but there's other things, right? It can tell us about the size of the heart. It can tell us if the arteries are blocked. It can tell us if there's fluid in the way between the sac and the heart. All of this is able to be gleaned from the EKG. So it turns out that the EKG really is, it's just a way to speak a language. The heart is trying to tell you what's wrong with it, and you need to know how to speak that language. So that's part of what EKG terminology is. It's part of what we're going to cover tonight. It's obviously, we're just scratching the surface of all of this, but giving you the 10,000 foot view of what you're actually seeing is really important. The other thing is, when the heart is ischemic, it has a lot of ways to tell you, and it's not just STEMI. That is the other thing that I feel like is a grave disservice that we're doing to our new people in the profession. We're saying, hey, STEMI or no STEMI, and then we just brush off the no STEMI things. But the heart is really a good communicator. We just have to be better listeners and know some of the signals that it's throwing off. So there's this little speech I give patients, and it is a judgment-free zone, absolutely. So there's a speech I give patients where I say that, the heart is like a house, because most people understand that. And when somebody comes in for chest pain, let's just take a case, for example. They've got chest pain and palpitations. As a PA, I'm going to get in an outpatient clinic, I'm absolutely going to get an EKG, one test. For their palpitations, I'm going to get a Holter monitor or a vent monitor, right? That's another test. For their chest pain, I'm going to get a stress test. For their chest pain, I'm also probably going to get an echo, especially if I hear a murmur. That's 4 tests. And some people will say, well, I only have one heart, so Why do you need 4 tests? It's because the heart has 4 parts, and they kind of look a lot like a house when you really lay it down. So it's funny because you have the vessels, which are the plumbing, and we call the guys in our practice who work on the vessels plumbers, interventionalists. We affectionately call them plumbers. And we have the electrophysiologists who are working on the electricity. And Tori is eloquently putting it in. Thank you so much. And muscle, okay, it shows us the walls, and the doors are the valves. We can only see the walls and the valves on the echo. We can see the plumbing on a treadmill, potentially other imaging as well, and the electricity on things like Holters and EKGs. So that's a little speech. Feel free to steal it. And understanding that there is a basic conduction system that's happening in the heart, and we're measuring that electricity on the paper, okay? So it's sending up signals, we're capturing it. And by these signals, we're telling a lot of things. So first things first, it's important to understand what you're looking at, okay? So going back to basics for a minute, the conduction looks something like this. We've got a sinus node, which runs the heart. And the sinus node makes a P wave, which is pictured here, which we'll go over a little bit more on this EKG. You could see a P wave here, P wave here. And so in a nutshell, actually, let me erase that. So let's go back to over here. You send the impulse down to the AV node, down to the bundles, okay? Down to the bundles. And this is what makes the heart contract at the same time, both ventricles, and produce the pulse. And so when you're looking at that, it's important to understand that you want this one to be in charge, the sinus node, always, 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 right? And so what you're going to look for to see if the sinus node is in charge is certain waves. So we're going to cover the waves, and if you know it, say it, no pressure otherwise. But let's label these real quick together. What is this wave here? What is that wave? Oh my gosh, yes, sinus makes P. Steve, you're so on top of it. Yes, absolutely, 100%. So let's do the next one. What wave is this here? So the first one was the P. This is the, good job, Nicole. Q, exactly. Good job, you guys. This is the first positive deflection after the P wave. This is also known as the R wave. Good job. This one is known as the S wave. So we have the Q, R, S. And then over here, this little wave here, anyone want to take a guess? Yes, Ashley, KJ, all over it. Mr. T, Steve, good job. And then over here, this wave is called a U wave. Good. Okay. So now that we've identified all the waves, now we know how to find them. So let's keep going. Let's talk about some rules real quick about these waves. Now, the first thing is that a P wave must be present. And if there is a P wave present, the sinus node is running the heart. It should also not be notched. And it should also, thank you, Tori, it should also be upright and small, okay? Upright in most of the leads. The QRS should not be too wide, and it should not be too tall or too small. If a QRS is too small, we should worry because it could mean that there's fluid blocking the electricity going up to the surface to be measured. There's a lot of other things that can cause it as well. Obesity, smoking, COPD, but we always err on the side that it's something bad until it's not. So pericardial effusion would be something we would worry about. And then lastly, the T wave should be upright in all the leads except for 2. The T wave should be, the term is inverted or upside down in 2 leads, and they are both at the top of the EKG. Does anybody want to take a stab? Yes, exactly. In AVR and V1. Everywhere else, the T wave should be upright. And because of that, the T wave should be upright. That tells you a lot, believe it or not. If a T wave is inverted where it shouldn't be, other places other than AVR and V1, we should worry. So I'm going to tell you a little story about this whole situation here. And this comes in handy later because in a nutshell, the P is the mom, the QRS is the dad, the T wave is the baby, and they should all be holding hands together. If the T wave is far away, that's often prolonged QT. If the P is super close, a lot of times that means you have a Wolff Parkinson's white. And yes, we are a family. That's a good song. We should actually play that. We should have that playing. So here's a good example of a discrete, beautiful P wave. Notice it is small. It is not notched. And the sinus node makes the P wave, which means that the sinus is in charge. And we are always looking for sinus rhythm. Okay, we're always looking for sinus rhythm. And so let's keep going with that. Now, the next wave over is the QRS. Again, that's the ventricles contracting, depolarizing, and then they repolarize over here in the T wave. We're talking about the electricity. So they've squeezed, they've depolarized. And this should, again, not too tall, not too small, but it should be no more than how many small boxes or how many, what's the time? Okay, we can use point something, we can use milliseconds, but, or small boxes, any way you want to slice it. Yes, 0.12, and the 0.12 to 0.20 is the PR interval. Yes, KJ. And so we want 3 small boxes essentially for the QRS. If it's over that, then we could have a bundle branch block, we could have other things going on. And then lastly, the T wave should be a little asymmetric, meaning leaning a little bit. And if it's not, then we have to worry. Yes, 3 small boxes. So there's another thing on here that is good to know that is probably gonna, if you've learned this before, it'll kind of, you know, we'll rehash it a little bit for you. But the T wave has an area in it that we get a little concerned about. That's called the relative refractory period. That's right here. So if an extra impulse comes in right here, that can cause something called R on T phenomenon, which can lead to arrhythmias like torsades, right? Which would be bad, torsades de pointe, which we'll cover tomorrow. But if you had an impulse come here on the absolute refractory period, nothing would happen, okay? So the T wave is very important because it has an area that's vulnerable electrically. It also tells us about electrolytes if it is potentially big. It also tells us about ischemia, believe it or not, in the shape of it and also the size. So the rock star of this whole situation is literally the T wave, okay? And Michelle is welcoming people in. Tori's posting the workbook. You guys are amazing. So the other thing that I would say is super important is the Q wave situation. Let's cover that real quick because we talked about the actual waves that should be there. The U wave should never be there, right? But you should have a P, Q, R, S, T, and then you should have no Q. Well, you can have a tiny Q wave, but if you have a big Q wave or a wide Q wave, again, that's the first negative deflection after the P, then you got to measure it, okay? So what you're going to do is you're going to take from here to here. You're going to cut it up into thirds. If the Q wave is at least a third the height of the R wave, then it is pathologic, meaning bad. And so at the end of the day, what do you do with that information? Well, it can mean new infarction. It can mean old infarction, but you need to sort it out. So what does that mean for you if you work in clinic and somebody has chest pain and they're seeing you, they've got Q waves, especially if they're new, these can form within an hour of an MI starting. So we need to be looking at those pretty hard. But if they're less than a third and, you know, not wide, then we probably don't have to worry about them. Probably. There's actually other times Q waves can come. I don't want to get too much into it because I'll drown you, but basically PEs can sometimes have Q waves, and so can one of the lethal disease processes that we always worry about in our young athletes, HOCM, can have Q waves. And we kind of talk more about that in our 30-day, but just know that you really shouldn't have a Q. If you do, you got to investigate it pretty hard. And what they look like in person, just to show you what they look like in real life, in the field, in the wild, is here, okay? You can see I colored that one. There's a tiny one here. And so this one is at least a third the height of the R. So it's pathologic. It's also in contiguous leads. That's another term that we are introducing to you today, is contiguous. So when you have leads that are fed by the same artery, they are contiguous. Contiguous is a term that we use when we talk about STEMI. So knowing what leads are contiguous is super important. And I will tell you that 3 and AVF are contiguous because they're both fed by the right coronary artery. And so you have a Q here that is pathologic. You also have a Q that is over here in AVF, and they are contiguous. So we need to be worried about them. And the machine is calling this a possible inferior infarct because it's seeing that. It's not telling you it is. It's basically leaving it up to you, clinical correlation advised. So it's pointing you in the right direction, which is helpful. Okay. All right. So we're going to talk about a couple of the T-wave bad guys. And I mentioned to you, so I wanted to just show you an example. I mentioned to you that T-waves, right? If they're really big, they're a problem. If they're really small, they're a problem. You have to have the perfect T-wave, which is here. This is what a perfect T-wave looks like. He's not too big. He's not too small. He's not pointy. He's not biphasic. He's just doing the right thing by being a little asymmetric and upright in almost all the leads, except for which ones? AVR and V1. So this one is an example of hyperkalemia. This one is an example of hypokalemia. And you can tell the difference because of the size, okay? So the other thing you got here is this upside down T-wave, but he's not symmetric, okay? So symmetry is another EKG terminology word we've got to learn tonight, because we never want a T-wave to be symmetric, which means equal size, okay? It's leaning a little bit and it's upside down. And why is that important? Because this means that the patient most likely has a big ventricle and it's not ischemia, so yay, not ischemia. And then this one here, we couldn't really comment on him with any definitive answer because he needs a 12 lead to say what's actually happening with him. You may have, this may be benign early repolarization, it may be nothing, but you need a 12 lead to really say. The other T-waves we can say with pretty good accuracy that they have either a problem or not. And Jose Ortiz is here. Awesome, welcome in. Now I wanted to bring an EKG just to show you, like, I guess we would call this EKG when T-waves go bad, when they go rogue. This is an example of, like, literally almost every T-wave is causing a problem. They're not following the T-wave rules, okay? So we just said that, hey, the T-wave should be inverted in V1 and AVR. They should be upright in all the other leads. Well, these guys are upright. So far there's a problem because that's not good. And then these T-waves, these guys over here, they're supposed to be upright. They're not. They're inverted. They're inverted and symmetric. Inverted and symmetric. That's bad. The only two T-waves that are getting off the hook are the ones here and here. They're doing the right thing. But everybody else is inverted and symmetric. This patient had a lot of things wrong with her and very abnormal EKGs. That's what abnormal looks like. And knowing the directionality of the T-waves helps you solve the mystery. And again, just pointing out all the problems this EKG has, and you need to know what normal is to know that it was a problem. Otherwise, you might just refer them to cardiology, but that would have been bad, okay? So R to R interval, that's another term that we want to make sure you understand. And that is what we're going to use tomorrow night. So bring that term tomorrow. We're going to talk about the regularity and of a rhythm. So if the R to R is normal, then, and it's regular, then we most likely are not dealing with atrial fibrillation or other bad things. We'll kind of highlight that a little bit more, but tomorrow we're going to ask you, is it regular? And you're going to look at the R to R interval to decide that, okay? And then also just understanding that the P, right, is the very beginning wave going down to the tiny little Q. It's not a third, so it's a negative downward deflection, but it's not a third. Going up the R, down to the S, a little S, going up to the ST segment, going up to the T wave. And then here is a line that turns out to be very important in the grand scheme of things. This line right here, it's actually called the TP. And we nerd out on this a lot. I don't want to do it today because I'm trying to keep this basic, but this segment right here is what we use to see if there is any ST elevation or depression, which is something else we're going to be looking for on the EKG to see if there's ischemia. But also we're looking at the interval, so the time it takes from the impulse to go from the P to the R, okay? 120 to 200 milliseconds, as KJ mentioned earlier. So that's an important time to measure. The time it takes to make the QRS complex is an important time, under 120. Notice that 120 seems to be a magic number here. right? So the PR intervals should be 120 to 200. The QRS complex should be under 120. And that's kind of a little secret sauce thing to remember. Now let's shout these out if you know them. Go ahead and type in the chat. What segment is this right here? We just talked about him. He is the, oh, these numbers might show up in our game. Nice, Carlene. PR intervals. Steve, yes. Yes. Annalise, good. KJ, wonderful. Okay. So this one here is called the, good job, Nicole. Good job. This one's called the, this one's called the, yes, this is called the R wave, but this is also called the QRS. And then Steve is already over here. Steve is like talking about the QT, and that's right here. And then lastly, tell me what this segment is right here. What is this segment? It's the most important one. We absolutely spot on, you guys, ST, okay? So we're gonna be looking at those. I have a feeling that Michelle is going to have some of those in the game to help you refresh those and make them really stick. And good job, yes, Vivian. Okay, so, hey, Teresa, Teresa's here. Teresa is a monitor tech. And so she'll probably come on with us tomorrow night and tell us all the right answers of the rhythms. She's usually spot on. And so this here is an example of looking through. This is another thing you'll do with your EKG, okay? And it's part of your 10-step system, which we'll cover later. But you're going to look at all these numbers here. And we're going to tell you that, you know, the PR, it should be between 120 and 200. The QRS should be, we talked about, under 120. It is. So those are good. The problem lies in this here, the QTC. The QTC is very long. It should be less than how much? Can you guys tell me? The QTC, oh, so sorry. Yes, it's going to be recorded. No problem. Be safe on your call. The QTC should be less than what? Absolutely, Laura. But it's allowed to be up to what? It's allowed to be up to how many milliseconds to still be called normal? So it should be under 500, yes. So Teresa and KJ are both right. Let me explain. So Teresa said 0.45 or 450. That's true for men, and 460 for women. Okay, so this patient being 713 is absolutely too high, and it's prolonged QT. So that would be something that we would worry about. But here's the thing, okay? Rule number one of EKG everything is you have to have a clean EKG. So looking here, you can see there's a lot of artifact. And all that artifact is messing up the machine's read. It is not really 713. So this was a case of looking at the T-wave. Now I'm going to tell you how you could have solved this. And this is going back to the family, a pattern recognition thing, which is why we teach you the family. Is it all coming together yet? Are you so excited? Because I'm so excited. All right. So if you go over, let me move that really quick. If you go over and you look for the T waves and you say to yourself, ooh, that's a T right there. Okay. The next thing you're going to do, you're going to go from here to here, and you're going to see if it is at least halfway. Okay. So the baby is actually not yet at halfway. The baby is still close enough to his own dad. Therefore, it is not really prolonged. And that's how you would actually see that. So that's the message is get a clean EKG. Don't be afraid to repeat it so there's no artifact if you can, because it will mess up the machine intervals. This is when they redid it, the clean EKG, and you can clearly see the machine called it 444, which is more accurate. You could go ahead and measure it as well if you wanted to double check. I will tell you that mostly the QTC is pretty correct from the machine, which is good news to know, unless there's artifact. Okay, so we're going to talk about this concept real quick of understanding that the intervals are significant, and talking about the voltage. Okay, so if you have high voltage, we have to worry about lots of tissue. If you have low voltage, we have to worry about either ischemia or something being in the way, or maybe potentially even something like amyloidosis, which is way over this class's head right now, but just know that it's on the thing. So we're just mentioning it. But I don't want you to be scared by that. understanding that we're just doing a concept check, that the QRS should be just right, not too tall, not too small. And the numbers matter. Here's my dog, Remy. He's the EKG reading German Shepherd. Remy's STEMI with Remy. And so you might have seen posts with him before, but he was literally named to match with STEMI, of course, because he's a STEMI hunting dog, as KJ said. So they do matter. And so this is a case just to kind of highlight that. And Sandra's saying something about voltage and axis are related or not. Voltage and axis. Potentially, yes. Potentially, possibly. If there's like a big ventricle that could potentially swing the axis, I think that's what you're asking. Yes, we do love Remy, absolutely. So this is a case to share with you the importance of looking at the intervals. So this was a real case, 51-year-old female who was weak. She had called EMS. Here you are responding to the scene. She felt like the water ran out of her. She became incontinent, which is always a bad sign that the patient had loss of consciousness or potentially a seizure, unless they just are always incontinent, but she wasn't. And she had a history of chronic neck pain. She was on methadone. She did some alcohol and cocaine and really didn't feel good. So she called 911. So they used pattern recognition, which is the secret sauce to really figuring out what was wrong with her. And she ended up actually going into cardiac arrest on them, torsades de pointes. They shocked her, they did CPR, and they got her to the hospital with this EKG, neurologically intact, with pulses. It was amazing. So they looked at this EKG. This is her door time EKG to the emergency department. And the question became, okay, what are we going to do? So we got to decide, are we going to take this patient to the cath lab? So they really scrutinized her ST segments. They looked at all of it. They looked for too small, too tall, any ventricle problems. But at the end of the day, this was a story about somebody who had something wrong with the family. So if you look here, that baby is very far away from his dad. The baby should not be halfway between, okay? And so that baby should be way closer. This was a case of prolonged QT, and she went into a torsades de pointe arrest. So really knowing these intervals and recognizing, I literally took it off here, but it was 5:12. I didn't want to give it away. I wanted you to look at the family to see that there was a problem. Because really, when you're doing this in real life, you need to spot high risk patterns. So they need to stick when your eye sees them. And the way to do it is to memorize what they look like. Yes, the numbers are helpful, but also knowing the family and kind of showing you why that's important. This was her EKG coming down from 512 to 441, which is normal, below 460 for a woman. And her T wave was, her QT was better after all her meds were taken off. So that was luckily good. Now we're going to just really quickly prime you a little bit for tomorrow night so you can start thinking about this, bringing these 3 questions to the game tomorrow, to our session, and also bringing these questions when you come to Gary's special event on the last night, asking yourself, is it fast or slow? Is it wide or narrow? Is it regular versus irregular? Okay, those are terms that we're learning tonight so that we can apply them. And remember, we're going to be using the R to R, which is right here, to see if it's regular. Now, we would actually need another R here to see, and we would be doing that on every R. So I'm demonstrating a regular pattern here, but we'll be doing that tomorrow. So just remember these questions. We'll be asking them for the rhythms. And also a little primer for tomorrow, just to share with you the rhythms and what we're talking about here. Again, sinus, AV, ventricles. The sinus runs the heart at 60 to 100. It also makes the P wave. If that goes away, it looks like this. And you will distinctly be missing the P, and you will be like, I don't know where the P is. It's not there. And if it's not there, that means the sinus node's not running the show. It means the AV node is. And this is a junctional rhythm. Yes, the baby is running away. So as KJ always says, sinus makes P. The sinus node does make the P. Now, this will be run at about 40 to 60 beats per minute. And then if that fails, the next guy to take over is the ventricles, okay? And how do you know the ventricles are running the heart because it is a wide complex. Wider than 120, that's where that 120 comes in. So helpful. And this is called idioventricular. If you're a medic, you've seen this before. You didn't like seeing it probably because it meant your patient was probably in cardiac arrest or on their way to. If you're seeing this in clinic, it's easy. You just have to call 911, right? And keep the patient alive. And then lastly, the patient can go into something called an agonal rhythm, which looks like this, which is where one little lonely heart cell is running the heart at the bottom of the heart. It's agonal, it's no pulse, no, not compatible with life. And that's kind of the end of the line trying to run the heart. We want the sinus node to run it. We want the P wave to be there. And hopefully it is each and every time. Now, here's a quick little way to estimate rate, because I just explained rate, but let's talk about an easy way to kind of look at it. Okay, so this is called the rule of 300, and this is how to use it. So the first thing you got to do, you got to find a R wave that lands on a thick line. So these are the thick lines here. You can see them easily, right? They're thick. And once it lands on the thick line, then you put start, okay? The next line over, you're gonna put 300, the next big line, 150, the next big line, 100, the next big line would be 75, but the next impulse comes in right here between 60 and 75, so that's probably around 64, and this is a great way to guesstimate. So this is called the rule of 300. I can tell you, you can use this to back up what the rate is being calculated for you as on your 12 lead. You can also use this if you just want to quickly calculate it. Where are you going to do this? You're going to do it on the very bottom strip of the 12 lead, because that's where the rhythm strip is printed. It's a long lead for you. You're not going to use the little 3-second strips. Okay, so now it's time to run through our workbook section. So if you have it, grab it. If you're watching this later on the replay, you can fill this in and then come back and check your answers, however you want to do it. But this is just designed that if you want to reinforce what you learned, let's go through this really quick. So the P wave, it corresponds to what contracting? So let's see if you guys know it. What's contracting when the P wave happens? What's contracting? Yes, Jennifer, Elena, good. The atrium. So go ahead and write that in, the atria. And the Q is initially a positive or negative deflection. Remember, it's right here. Is it positive or negative? Good job, Jennifer. KJ, also Teresa and Vivian. So it's negative, and it's normal if it's less than, what was the number we gave you? What was the number? Adelise, Jennifer, and oh, nice job, you guys. Santina, Teresa also. So yes, if it's 1/3, less than 1/3, okay? Now, the 3 waves of the QRS represent what is depolarizing. So what is squeezing? What part of the heart is squeezing? Ventricles, good job, okay? Ventricles. And then if the rule of thumb is the wave after the P is an upward deflection, it is an R wave. If it is a downward or negative deflection, it is a, here's the hint. It is a, here's the hint that's right here. It is a Q. Good job. It is a Q. If it's the second negative one, it's the S. Okay, so good job. And then R wave of the ventricles, this is the first positive deflection. And then the T wave, let's see what we have to say about that. Hey, Jean. Jean's just logging on. So T wave, it should be positive. Good. Steve, I like your answer. And Eileen, welcome in, Eileen. It's been a while. Oh, look at that. Carlene. Yes. AVR and V1. Okay. Should be upright in all the leads except for AVR and V1. Now, we do have the answers to this posted up in the guide section under day 1. So don't despair. They are up there if we are going too fast. And then here's a couple more. Okay. So the U wave is often seen after the what wave? Where is the U wave coming after usually? Nice. The T wave. Good. One of the causes of the T could be what kalemia? Is it hypo or hyper? Yes, hypo. Good job. Nice, Jennifer Comito. KJ. And then the delta wave, okay? The delta wave we didn't talk about, but it is a slurred upstroke, right? and it's associated with a short PR interval. We didn't talk about that. You'll see that it was WPW. Perfect. You guys are nailing this all over it. What's up on Facebook and Zoom? Okay. Now, the PR interval is the distance from the what of the P wave to the beginning of the R. So where do we start measuring? We start measuring from the beginning of the P. Okay, good, Carlene. Okay, let's refresh. Let's put it in the chat. What is the PR interval? It should be what to what? What's those numbers? You know one of them is going to be 120, right? Because 120 all the time. All right, 120 to 200. Perfect. Good job. Or 0.12 to 0.20 if you like that better, either way. And they're both right. Now, the PR segment, we already talked about that from the first of the P to the end or the beginning of the R. The ST segment, we're going to look for two things. I know it's old school, KJ, and I'm old school, but I transitioned at some point. I don't know when. I think when our EKG started giving us milliseconds. So ST segments, we're looking for two things. Two things. What are they? What are we looking for? Hey, Jennifer, welcome in. Elevation and depression. Eileen, you got it. So let's put that in our workbook. We're looking for elevation and depression. And then let's see, where are we at? Okay, ST depression. So there's lots of things that cause ST depression. We're going to cover them. One of them is hypokalemia. Another one is cardiac what? Anybody have any guesses? It's the most common cause. Yes, ischemia, good job. And medications, there's one that will do it that we know of that's pretty common. And it starts with a D. Starts with a D. Oh, yes, digoxin. Good job, you guys. So digoxin also causes ST depression. Now, the long QT, what can that lead to that's bad? The long QT. The long QT can lead to torsades. Good. You guys are all over it. We'll show you what that looks like tomorrow, but torsades is a lethal rhythm, and we absolutely don't want to miss that. So we always want to prevent prolonged QT. That's why knowing the distance of the QT is very important. Anything below 460 is normal, unless you're splitting hairs, 450 for a man, 460 for a woman. Now, if a beat has a regular R to R interval, right? That's good. Well, we're looking at this R to R to see if a rhythm is regular, or what's the other thing it could be? What's the other thing it could be? Yes, Claudia, these answers are already posted and they are in the guides section at the very top of the Facebook group. And you just go to day one and it says day one answers. So I know it's good to go over this and you can even test yourself. So yes, irregular was the answer. Good job, you guys. All right. So which thing that you learned about tonight are you most excited? So type in the chat, what are you most excited? What did you come away with tonight? Just curious, okay? Just curious, what did you come away with? What are you excited about? Tell me one thing, all the things. Yes. So what's the one thing you're walking away with tonight? And maybe nothing, right? Maybe this is all just review for you guys, potentially. Maybe you're excited about all the things. The family, okay, good. I like it. I hope that sticks. Here's a way to make it stick. Go tomorrow, wherever you work, and go teach somebody the family thing. Go draw it and say, hey, I want to show you this cool thing. Helps you pick up prolonged QT, helps you pick up Wolff Parkinson's White, helps pick up, blah, blah, blah. And then you can share with them. So fun. So basic 12 lead, that's going to be night 3. Yes, I know. Can't wait for tomorrow too. We're going to do arrhythmias tomorrow. And Stephanie likes the family. So we're going to give away a prize tonight. And also I wanted to really quickly, before we give away the prize, actually, I'll tell you what the prize is, but then we actually need to have you put in a hashtag. That's how we do this. But you're going to put in a hashtag EKG, if you want to win the prize. But let me show you what it is before you put the hashtag in. One lucky winner is going to win an EKG workshop kit. So this is a box that comes with Prezzies. these. If you have one of these, tell us what you think. Tell us what you think. Oh, it looks like Malika Tori who needs the workbook. So please, if you could give her the link again, that would be great. All right, awesome. And I'll be choosing a winner tonight and announcing on Facebook after we end. Later tonight, I'll be announcing the winner. So if you win this, you're going to need to send me your address, your mailing address. Okay, so let me show you what's in this box. Everybody already wants to win it, but you don't even know what's inside. Let me show you the goodies. Okay, so this is coming to you if you win. Okay, this is a little RCAT window. It helps you figure out the heart rate. It helps you see the ST elevation. It helps you look for the intervals with these red things here. It helps you look at identifying where the STEMI is, what artery is affected. This is so great. The guy who makes these is coming on night 3 to do our arrhythmia class. So I'm super excited. And we're going to send you some crayons. We're going to send you these crayons that have red, blue, and green, because that's how we color code our EKG in our class. Okay, now there's also going to be a 17-page workbook coming to you with real EKGs that you can use. There's also exercises in here to label things. There's real EKGs, as you can see, that don't have, they're not perfect. They're actual EKGs that you can practice on. There's also a cheat sheet in here. There's a EKG you can use that is, you can color code. It's a normal EKG, so to speak. And you can use that to color code. And last but not least, you will also win one of these, which I hand paint. Every time we actually have a 30-day EKG challenge, this is the kit that you get as a gift for joining us, but one of you are going to win it tonight. But I have a little painting. These are little mini paintings. Come on, a little easel. And you can probably see I have some in the background, like here's this one. This one's kind of fun. But they're all different and they're all custom. And so I want to tell you a little fun story really quick, because anybody who's ever gotten one of my art pieces or ever bought them, your value of the art is about to go up, because I was just selected to be an artist in San Francisco of the I Left My Hearts in San Francisco campaign. So that's happening. And once that actually is announced and they're actually in like a gallery, your value of your art is going to go up. So you really want to win this, because one day you're going to have a piece. Okay. So anyway, we're so excited. Yes, KJ, I love this shirt too. KJ actually got me this shirt. Isn't that so sweet? And I'm so excited to wear it and what it represents. But anyway, I'm going to be giving away tonight the prize, but also we're going to see you tomorrow. We're going to see you same time, same place. Michelle, do you want to kick off tomorrow for us with your game? What do you think? Do you want to kick off or do you want to end the session? I like the kicking off idea. What do you guys think?
I can do the review. I've been writing down everything that you did today, so we can do a quick review and see who wins. You got to get your typing fingers going, because we're going to pit the Zoom people with the Facebook people, and we'll do maybe we'll do that Mars game again, because that one's always seems to be kind of fun. And I'll change the question, so you won't, if you watched it last time, you won't get the same answers.
Okay, awesome. So it looks like we had a couple questions. Thank you for chiming in on the questions. It looks like we're talking about the mom, dad, baby. So we were just talking about the mom is a P, the dad is the QRS, the baby is the T. And so we're just looking at the relationship between them. And thank you, Tori, for really highlighting that. The session can be viewed again. We're going to be putting it into the guides, which is at the top of the Facebook group. And then usually the next day, we give you a replay link that's outside of Facebook if you want to view it there. And you can, all the 3 sessions will be on that link, and they're really easy to watch. So yes, do I have a minute to discuss the layout of the 30-day EKG challenge? Yes. The layout is basically this. We start on Monday, which is next week, and we basically start with EKG terminology, but all of it. We then do basic rhythms. We do basic 12 lead, hands on, and then we do, class, and then we do the basic 12 lead practice session. And then after that, we do a 3-hour hands-on workshop, and we use everything in this box. We use the EKGs, we use the workbook, we use the crayons, and we do like an actual hands-on time to practice everything you've learned. We also have every other week on Thursday, we have something called study halls. And study halls are really cool because our master, David White, comes on and he takes EKGs that you've submitted to him and breaks them down for you. You can also interact with him, ask questions, don't have to be shy. And then we also do, as KJ knows, KJ's in the 30-day EKG group, we also do bonus sessions throughout the year, other little workshops and other little classes that are cardiology related. We even have med math for medics. We have a ton of stuff. And I'll kind of show you guys more on night 3, a little behind the scenes, what we do, and show you guys the calendar. But in a nutshell, it's a great class because it has live stuff like this, and it has recorded stuff to go to. And everything that we've done for the last 3 years in the group is available to watch. So what's really cool is somebody joined last week, actually between actual official challenges. And he said to me today, he said, you know, I'm a beginner, where do I start? And I was like, actually, that's the great thing. You can start with us again October 9th, but you get to watch any session on anything we've done. So the drawing of the coronary arteries, you can watch that while you're waiting for us to get started again. You can binge watch on anything you want because there's 3 years of content, which is so fun. So anyway, that's the skinny for tonight. And Carlene, Carlene, would love if you invite more people to this group. So what you can do, go to the 3-day EKG challenge Facebook group, go to the top, hit invite and choose who you want to invite, and they'll just automatically get into the group. And we'd love to have anybody who wants to learn. Or as you can tell, we're a very positive crowd. They would love Michelle's game tomorrow, especially, and Gary's bonus session. So anyway, that's it for tonight. And yes, it actually is for 6 months. Thank you for mentioning that, KJ. Yeah, we actually do. What we guarantee you is that if you stick with us and you do the first 30 days of classes over however long you need, right? If you do that, you're going to feel more comfortable and confident. And then you get an extra 5 months to just binge watch. But of course, after that, we give you an opportunity to come in and join us longer. Honestly, most people stay. They stay in the group because we keep adding new content. So yes, you get to go through the same core classes again, but we're always adding new guests. In fact, this week for guests, we had a lipid coach. We had 2 different coaches, a heart failure NP or PA. She did a guidelines update. And then an ERPA, Mike Sharma, who did a guidelines update on the new STEMI equivalents and other new workup stuff that we need to know. So literally, we are always keeping it fresh for you. And we are also currently working on something else, which I can't say until it's official, but also could be potentially really exciting for you guys. And yeah, we're just super thrilled that you're here with us even tonight, just to learn some of the basics. And my hope for you is that you walk away with some foundations and really start to see that it doesn't have to be so hard. That's my goal for you. So I'll see you guys tomorrow night. And oh, sorry, there's another question. Hold on. John Cross, I know you're in here with us, John. I love having you in our 30-day EKG challenge. You are amazing, and I'm just so grateful for you. The sessions, okay, so the sessions in our 3-day are 5:30 tomorrow night and Tuesday. And then our sessions are varied in the 30-day, but they're mostly 5:30 PST, although Michelle's classes are at 4 PST, David's are at 2 PST, so they're varied. So we have some that match up better with like East Coast and some that match up better with West Coast, but everything's recorded, so that's the good thing. All right, I think that's all the questions. I am in Old Austin. Cool, you're in Texas. Well, we're gonna be in San Antonio this week, so maybe you should come down and say hi. All right, you guys, see you tomorrow night. Thank you so much, everybody, for rooting each other on. Thank you, Michelle. Thank you, Tori. Thank you, Ruben. We'll see you guys tomorrow.